SMRA update on contrast agents.
Okay, thank you, Liz and Giles. It's a great pleasure to be here in beautiful Nance, and I'm going to talk a little bit updating some concepts with contrast agents. I want to first talk a little bit about the benefits of gadolinium MRA. It's used for shortening the T1, which enables you to boost up the signal to noise of your MRI angiograms to get higher resolution or faster. Also, the gadolinium contrast distributes throughout the blood in a manner analogous to the way catheter angiography contrast distributes throughout the vessels, so that the images resemble CTA and catheter angiography more than the non-contrast MRA techniques, and thus are more familiar to the physicians who are having to look at them. Also, post-gadolinium, we get excellent visualization of the veins and also inflammatory changes. Then I'm going to talk a little bit about the evolution of bolus timing, because the bolus timing is very critical to getting the best quality, and there's just been a huge advance recently in how to improve the timing of the bolus for MRA. And then I'm going to talk a little bit about iron oxide, ferromoxetol, which is more of a blood pool type of effect, which doesn't require any timing at all. And that leads us finally into gadolinium safety, which includes the issues of stability, which can have problems with NSF or gadolinium deposition or interference with laboratory testing, and also the issues associated with allergic reactions, which do not distribute among the contrast agents in the same way. And finally, I'll give a little taste of some of the latest talks, papers using innovative contrast agents such as fluorine-19 or carbon-13 or oxygen-15. All right, so that's a lot to give in a very short time, but we'll just buzz right through super fast. And I noticed that Paul Finn couldn't make it, and I have a couple of his slides I'm going to show, so that'll hopefully fill in the gap. Here's an example of a patient where we see the arterial phase. On the left, this patient has an aortic coarctation, and after the arterial phase, we get the delayed phase, which shows a lot of things enhancing, including the veins, but it also shows a thick rind of enhancement around the aorta wall in a patient with Takayasu's aortitis, causing an inflammatory reaction and also causing this aortic coarctation. Now, bolus timing has improved incredibly from the early days when we used to just guess, and we heard that nice example from Giles about using a test bolus, but not just a test bolus. He used the test bolus as a way of measuring perfusion, and then he got the test bolus information for free. And then later using relatively lower temporal resolution, time-resolved MRA, and now with these advanced image acquisitions, for example, using spiral sampling that samples the center of K-space with every TR, and these spiral interleaves can be updated at an angle of incremation equal to the golden ratio, so that they very nicely sporadically sample K-space. And what this does is it enables you, if you think about, say, 60 seconds of data, to get several phases. Every, say, 12 seconds, you could get an entire sampling of the data. But since those spiral interleaves are being collected sequentially, you can also just slide your window along and get whatever temporal resolution you want. And in this way, you get a huge increase in the potential temporal update rate. And there are also some Bayesian approaches to do the reconstruction, such as a tracer or Proud or compressed sensing, which further enhance the ability to improve your temporal resolution. So here, work from Pascal Spinsmile, who developed this spiral technique, you could see how using the 3D axial MRA applied in the abdomen for imaging the liver, he gets multiple arterial phases, and then several venous phases, and then at the end he gets a hepatocyte phase using gadoxetate, which has some biliary excretion. Here, playing the dynamic MRA as a time series, you can see this hepatocellular carcinoma. This is a slide that Liz already showed, also from Pascal, in which we see that same data set, instead of reconstructed at 3 seconds per frame, reconstructed at 4 frames per second. Now, one problem that emerges is, which do you prefer? More images or less images? And increasingly, people want all the information on fewer images. And we're starting to reach information overload. So if you collect your super high temporal resolution data and map through it, you can figure out where is the arterial phase and reconstruct that into an arterial phase image, and where is the portal venous phase and reconstruct that. Let me just give you an example of how this can work. So here we have the 4 frames per second reconstruction, and we could call, for example, the peak arterial enhancement, make that an arterial phase. And then a little bit later, we can call that the portal phase, and here a little more delayed, maybe an equilibrium phase. Here, the hepatocyte phase. And this enables you, a benign hemangioma, to more effectively sample the data that you want to see to make the diagnosis without having to have image overload. Here, that same excuse me, technique shifted to the coronal plane during the hepatocyte phase, also showing the peristalsis in the ureters. Oh, for some reason, all right, maybe my videos are not working here. Click maybe here. Yeah. Whoops, going the wrong way. We'll skip over that. The group at NYU, led by Dan Soderson, has done the same thing using a radial method instead and reconstructing along different dimensions. He, as with the spiral technique, can have a low temporal resolution of fully sampled data, but then higher temporal resolution from less heavily sampled data that can map in a sliding window technique, or it can map along different dimensions, for example, a cardiac motion dimension or a respiratory dimension. The same data set enables you to interrogate the data in different ways, post-contrast. Now, no discussion of contrast would be complete without this spectacular image from Steve Reeder. This is the one that also, yeah, it doesn't work. Okay, well, we'll skip over that. Where he starts at his first station and using he does time-resolved MRA at the first station and reconstructs on the fly, and when he sees the contrast arriving, then he moves down to the next station and so on. And for this, he used his caper technique, getting super high resolution all the way down to the calf station. Now, for us mere mortals, one way to improve bolus timing is to modulate the flow. And for extremities, this can be done by applying blood pressure cuffs to the extremity so that you either compress the arteries or the veins. Here in this example of a bolus chase, you could see in the calf station on the right side, there's venous contamination. But this patient came back and on the repeat imaging, 60 millimeter of pressure was applied to each calf with thigh blood pressure cuffs, and the exam repeated, and this delays the arrival of the venous enhancement and prolongs the arterial window, making bolus timing much easier to perform. Here's just an example where the 60 millimeters of mercury is applied in the thighs, and the third calf station was repeated multiple times. And in this patient, you could see how long these cuffs can maintain an arterial phase in the calf station so that the bolus timing is easy to achieve. All right. Now we have a couple of slides courtesy of Paul Finn, who has developed a technique where he gives the pheromoxetol, which is a blood pool agent, and enhances both arteries and veins, and collects data that is bin to both cardiac and respiratory motion. And from that data, he can then bin it in such a way that he can get short axis images. He can get, for example, end diastolic images where you see the atria are contracted and the ventricles are dilated, or that should be end systole, where the ventricles are contracted and the atria are dilated. Let me just show you this in his video format. All done without any bolus timing because he gives the pheromoxetol, which is a blood pool contrast agent, enhancing all the blood. And pheromoxetol is nice because it doesn't tend to have any parenchymal enhancement. It also has a very long half-life for uptake into the body iron stores, maybe 10 to 14 hours. So there's a very long period of excellent improvement of the blood signal. Here again, extracting cine information from the 4D music data. And this also enhances the data from phase contrast MRA for flow mapping, 3D flow mapping or 4D flow acquisitions as well. And we've heard other people mention pheromoxetol as an iron oxide agent, and it's been around quite a while. In fact, as I was looking at the papers on this, I was amazed at how many people have published articles using pheromoxetol for MRA. Back in the late 90s, referring to it as superparamagnetic iron oxide. And then the actual pheromoxetol that we're using today came out around 2000, and you could see how many papers there are published in PubMed using this iron oxide for MRA. And it never really took off in those early 2000s, but when NSF came along, suddenly you could see the interest in iron oxide really started to rise because it is free of gadolinium and doesn't have any risk of NSF. And in fact, as Giles has already mentioned, it is commonly used in patients on dialysis to treat their iron deficiency anemia as an IV iron therapy. But then around 2015, a black box warning came out because of an excessive number of reactions, presumed allergic type, and a fairly large number of deaths. And the bolus administration was banned, and extra precautions are recommended when using this. And so since that time, there's been a little bit of a fall off in the enthusiasm. But on the other hand, Paul Finn's group has, especially with work from Lian Ning, looking at the use in MRA over multiple centers has shown that perhaps this allergic reaction risk is overstated. And maybe it's not as bad as people think. At least the use in MRA doesn't seem to be that dangerous. Now I want to talk a little bit about the differences in the properties of gadolinium agents. And for MRA, we really want to have the maximum relaxivity, so we get the greatest T1 shortening. And the protein binding agents, as a general rule, have higher relaxivity than the gadolinium preparations without protein binding. For the ones that don't have protein binding, Gado Butyl is an exception, which I've listed as 4.6 plus because different papers have different relaxivities, all of which are greater than 4.6. And so that will give you the best quality on an MRA study to use the highest relaxivity. On the other hand, and the excretion half-lives are similar. Okay. The gadolinium can also be viewed as ionic versus non-ionic. And if we look, and there are a couple of exceptions, if we look at the ionic gadolinium, you could see it has higher osmolality and higher viscosity, but longer half-life for dissociation in the presence of hydrochloric acid. And so that tends to make it less likely to dissociate, more stable, less likely to cause NSF, less likely to have GAD deposition in the brain. The non-ionic gadolinium has more readily dissociation in the presence of hydrochloric acid with a shorter half-life, but it has lower osmolality and lower viscosity, which helps to contribute to a lower rate of adverse events. So patients in whom you're worried about stability issues, you may want to be thinking more ionic. Patients who you're more worried about contrast reactions, thinking more along the lines of ionic. Now, if we compare to iohexol, which is a non-ionic iodinated contrast, you could see that the osmolality is similar to the non-ionic gadoliniums, but its viscosity is much, much higher, and that's why non-ionics iodinated contrast agents may be the reason why they have more allergic reactions. Another interesting exception is Gado Butyl, which has a high osmolality because it's packaged at double the concentration of other gadolinium compounds, and it also has high viscosity for that reason. But it has a very long half-life in the presence of HCl because it's macrocyclic. And then there's the ionic gadoxetate, which is a linear agent, which has a very low concentration, and that gives it a low osmolality even though it's ionic, and also a low viscosity. There's been recently a meta-analysis looking at 10 papers, nearly 1 million patients, rates of allergic reactions that shows these effects on a large scale. So if you look at gadodiamide, which is a non-ionic linear agent, it actually has the lowest rate of allergic reactions. Magnavist, which is linear ionic, no protein binding, has a higher rate, but still lower than all the others. Now these gadoxetate, gadobenate, and gadophosphate all have protein binding and are linear, but have a relatively higher rate of reactions. Presumably the protein binding is contributing to increased reaction with the immune system. And then the macrocyclics also have a higher rate of reactions compared to the linear agents. So it appears that ionicity, protein binding, and macrocyclic structure, although all contribute to favorable properties of gadolinium, seem to increase the rate of reactions. This is a recent study that came out looking at all of the published cases of NSF that have been in the literature. This actually just came out a month ago in radiology, showing that only 7 patients with biopsy-confirmed nephrogenic systemic fibrosis were reported related to exposures to gadolinium-based contrast agents that occurred after 2008. So it would confirm that the measures that have put in place to reduce exposure to renal failure patients to the higher risk agents and to overall reduce the dose of gadolinium have contributed to a near elimination of NSF. In addition, cure was reported in 12 patients. So the early reports of NSF having no good treatment, now that's no longer the case. Actually, there are the possibility to cure patients, especially if you can restore normal renal function. But replacing NSF as a concern is now the issue of gadolinium deposition. And this is a paper also recently from radiology, and it builds on the work of Kanda, who first noticed gadolinium appearing in the dentate and globus pallidus. And here you could see the dentate nucleus after 6 administrations of gadolinium, and then after 12, after 24, and in this patient after a total of 43, the dentate is really jumping out. And also substantia nigra, and red nucleus, and globus pallidus, and we now know the pulvinar. We now know the gadolinium is all over the brain and actually all over the tissues, all over the body. And so this may also motivate people to use the macrocyclic agents, which have less uptake, deposition in tissues throughout the body compared to linear and especially non-ionic linear agents. All right, the final thing I want to mention before finishing is that really our goal is to get contrast between the contrast agent and the background tissue. And one of the best ways to do that is to use something that is not present in the body, such as, for example, fluorine-19, or carbon-13, or oxygen-15. And there are a couple of papers that have images from the use of fluorine-19 MRA here at 1.5 Tesla using a perfluorocarbon substitute blood nanoparticle. And here you see the left coronary artery, and there's the background proton image in a mouse. Here, another example, looking at the aorta using fluorine-19, and finally using sodium gadofluorine nanodots for MRA in rabbits. So I think I'll end here just with the exciting possibility of new contrast agents and the exciting possibility that NSF is nearly eradicated, and the exciting possibility that bolus timing has evolved to the point where there are many incredible solutions, to the point that we're in image overload, and also indicating that iron oxide and non-gadolinium possibilities may further revolutionize contrast-enhanced MRA. Thank you very much.